Rohit, myopia, as you rightly said, our aim is to somehow arrest its progression. And nowadays, because of this pharmacological industry entering into it, and BCJ approval, FDA for this, low dose atropine drops, and wealth of evidence showing that it definitely can decrease the incidence of myopia. So really thankful for all these panelists who have joined as speakers, who have joined at a very short notice. And we all know that Myopia Week is being celebrated. I remember a couple of months back, Rohit, took this initiative, and under the age of AIS, he brought out a booklet. Rohit, you remember a couple of weeks back in Meridian, we were discussing a lot about myopia. And a lot of discussions happened because people from all across India had joined in this endeavor, and Rohit is actually into it. And I request him further that he should, and Namrata also, we should after this, we should go public also, because our aim is to reach public, and public awareness is has to contribute if we ophthalmologists have to decrease down this incidence. So we all know, you see today, honestly, the incidence is so high, it's virtually assuming a endemic or epidemic kind of proportions. See, there have been figures which say 1 in 2 children, could be myopic. And by around 2050, it is assumed that nearly 5 billion people will be suffering from this potentially preventable visual loss and increased risk of sight-threatening complications which go along with myopia. It's not just a minus number only. Minus number can be eradicated or give them glasses. In our country, in fact, 7 to 10% people suffer because of lack of glasses also. What happened recently, which everyone knows, COVID significantly raised this burden. And COVID lockdowns with increase of near vision activities, all school, both children as well as teachers, taking to screen for everything. And very importantly, less time for outdoor activities. And this resulted in, spike, and all the epidemiologists would agree that this is a spike in prevalence and incidence, new case of myopia, and also the progression of myopia. So what I thought was, it's a collective voice. It's not just, we at this webinar making noise about it, but it's a collective voice which should involve eye care professionals as well as the industry. Like, Todd has been kind enough to, partner with us. We need industry partners, we need public, we need parents, we need children. And for all this awareness, if we have to make a dent in this effort. In fact, all of you know that, Singapore and countries like, a lot of countries in Southeast Asia have made mandatory in the schools that a 2-hour break, outdoor break with the, from the school activity has to be done mandatorily. I don't know whether, India has done it or not, but we have to approach the education ministry and other, concerned people to, help us. And this awareness campaign will move only if there is a collective effort, maybe from AIS, then ministry, education ministry, then public, even parents. So then only we can, then only whatever vision I think Rohit has, then only we can do something about it. Aim is to, reduce the onset. Aim is to decrease the incidence. Aim is to decrease the progression. Aim is to decrease the complications which may happen along with it. And I think all the people, are here to they'll discuss. But I will take you to the only retinal issues, because I'm not an epidemiologist, but my main aim is to scare to people that in case myopia is there, but all it can cause in the retina. And it's not only glasses, but it can cause blindness if not tackled in time, which can be a permanent issue also. Like you see this detachment, although these are now tackleable, with the modern MIVS surgery. But believe me, if myopia, like we said, 5 billion, so a lot of people may land up in such issues also. Like giant little deer, you see this is a high myopic lady actually, lower, ultimately we could tell the retina. But we do not want people should, move on to this stage. And there are issues, with retinal detachment can have peripheral breaks, giant tears, macular holes, and macular changes also. So many things can happen in retinal detachment. So, like, classically, people have been telling that, if you see a detachment and a hole in the macula, just seal the break. But present day, all of us, do a MIVS surgery, and it works pretty well in these patients. This is not meant for this, but I'll just, tell you that what can happen in a patient who ignores, and this was a bullous detachment, which has a macular hole also and peripheral breaks also. This involved surgery because two things had to tackle: the peripheral breaks also and macular hole also. So there are a lot of controversial issues into it, but we prefer to do it at the same time under PFCL. After doing vitrectomy, put in this dye to stain the ILM, and under PFCL bubble, we advocate that remove this ILM membrane, and which comes out. If you do not use PFCL, then there are issues, but a lot of people do without PFCL also. So this ILM comes out generally, unlike a idiopathic macular hole, where it may come very easily. Here, it involves some degree of effort, and it rolls, makes it coil because of the weight of the PFCL. It becomes structured like this. But this patient, ultimately, we could, peel this ILM very effectively, and then tackle the peripheral breaks also. And fortunately, this is the technical, then you do an exchange and come out of it. Aim is not to show the such surgeries. This was another patient who had macular hole in a myopic patient. It's a very high myopia. Rohit was talking about 6. This lady had 18 diopters myopia, pathological myopia. And you see the OCT picture here. And this surgery, again, I will not go into because I already shown one of them. And this was the end result of this patient. The upper one is the post-operative period. And lower right, you see is the detachment because of poor contrast. And this is the OCT picture post-operatively. The lower one is pre-operatively. This is another patient who had the macular hole plus a lot of other changes. This patient post-operatively looked good. So this double trouble can happen in patients of myopia. So we are surgery in such patients and tackle both macula as well as the peripheral breaks. So, other things that are challenging is that, this patient has incidental schisis which are picked up, but vision was very good. So I generally don't want to, interfere in such patients who have such alarming OCT picture, but the vision is 612 or 69. So myopic maculopathy is another area where, a lot of research is going on. One was detachment, which I just covered. One was macular hole, which we also covered. But maculopathy assume, 4 or 5 entities come under it, what we call MMT, myopic maculopathy, fractional maculopathy, which can have VMT, ERM, schisis, hole, with RD, without RD. So these are a couple of pictures again to, show you all this, which can be tackled nowadays. But best is to nip the bud. Basically, do not allow myopia to progress, or do not allow myopia to occur in the first place also. That the aim is to preserve this vision. So this was another patient, young patient actually, this one, where, we had detachment and macular hole. So this lady also had this schisis with macular hole covered. This gentleman, in the right eye had this schisis plus hole, got settled only with air injection. So it's not a single entity, maculopathy. There are 5, 6 entities which now come under MMT. And my approach always depends on visual acuity, because I don't want to treat OCT. And in fact, if OCT, along with vision of 618 or less, because these patients, you see, our aim should be to do no harm. So I enter the eye to do tackle all this, because macula is atrophic. There's a lot of staphyloma is there. Contrast is very poor. Surgery is not so simple. So only if the patient is symptomatic, or if the vision is very much compromised, then only we enter, and not merely OCT, which I showed, that we tackle this.